If you do have questions, I know that it's been a very diverse presentation, lots of stuff to digest. I think we're going to be answering questions on a macro level, if you will. We're not going to be making personal appointments right now to go through different diagnoses and that type of thing, but by all means, does anyone have a question? Oh, look at this. Where do you want to start? We'll start back here in the, with the black shirt and the long sleeve. Well, the microphone comes back there. I'll remind you, there's also some evaluation forms and whatnot on your desk. We'd invite you, on your tables, we'd invite you to fill out. So, yes.
Perhaps one for Dr. Dodd. You talked about prostheses for ankles, for ankle replacement. Obviously, they exist for hips and knees. Is there any work being done on prostheses for all of the other bones in the body that might be subject to arthritis?
Yeah, I mean, there's constant research going on as far as joint replacements in all other areas of the body. Some of the joints in the body, you know, I mean, I'm hoping that where we're going is actually more of a biological solution to these problems rather than a mechanical solution. It would be nice if we could replace arthritic joints with normal tissues, so restoring cartilage and some of the research that was alluded to. There's always new things on the horizon, but be careful of what you read about, because, you know, as the internet is great for information, it also gives a lot of misinformation. And so I have lots of patients who come see me about implants that, you know, are in trial phases, or they're just designs that they read about on the internet that aren't clinically available yet. So as far as joint replacements, I mean, we can go as small as the knuckles in the hand for people. That's very common for rheumatoid arthritis. In the foot, foot and ankle, the only replacement, well, we have a big toe kind of replacement option, and the ankle, but then you can go elbow, shoulder, hip, knee, and that's kind of the extent of it from a clinical standpoint now.
Who wants to be next? Over here.
Hi, my question is for Andrew as well. You showed some examples of people who have had hardware in their ankles. If that hardware was to be removed, is the bone going to, is there more of a chance of the bone coming down and destroying the cartilage to give further arthritis in the future? Or is a person better off to leave hardware in their ankle?
It doesn't matter too much. For the most part, the hardware that we put in is designed to be temporary. It's only there until the goal of the surgery has been achieved. So whether that's fusion of a joint, like I talked about, or healing of a fracture, once the fusion or healing of the fracture has taken place, the hardware is kind of just along for the ride. So in many situations, if it's causing a problem, it can be taken out. But my philosophy is usually, if it's not bothering you, leave it in, because it's just another operation which has risks.
Yes, right here.
A question for Dr. Dodd. Is there anything that we as individuals can do to be proactive in either supplementation or anything else to help stave off arthritis and maintain a healthy cartilage?
Some of my colleagues actually might be better to answer that question, to be honest. Unfortunately, I'm the guy who you get to once this problem's already happened. So orthopedics in general, admittedly, we're not the best at discussing prevention. I mean, the things that I would espouse for prevention are healthy weight management, active lifestyle, reducing injuries and impact activities. I mean, if you have knee arthritis at any joint, running and repetitive impact activities probably aren't the best choice for you, and low impact activities are better. But I don't know of any scientific evidence behind any specific supplements that prevent arthritis, as far as I know. But as I said, we might open that up to my colleagues here who might know more about that.
The top two predictors of knee and hip osteoarthritis, the top two predictors are being overweight and not being able to do what's called a time to get up and go test, which means you're sitting in a seat, you get up, you walk about 10 feet, turn around, come back, sit down. You're not allowed to use your hands to get up. So a slow time to get up and go, or an inability to get up out of your seat, walk, turn around, come back, and sit down without using your hands, those are strong predictors. So we're back to Dr. Doyle-Baker's talk on training. Weight management is key, and doing powerful type activities in a neuromuscular training program to enable you to do a timed get up and go test. Those are two of the best predictors of whether you will or will not continue down the road of osteoarthritis.
Tish, anything?
And just to make sure that we add about diet in there. Diet's critical, so make sure that you have enough calcium in your diet and protein, and of course stay away from fatty foods and sugar and things like that if you can. And if you have to drink alcohol, which possibly is a thing that you might have to do, make sure you do it in moderation.
To the back of the room here.
Oh, hi there.
They'll bring the mic over.
Oh, sorry. I just have two questions. So one, Dr. Tish Boyle, you said that eat more protein, but doesn't that go against the gout Paul's theory for rheumatoid arthritis? When you eat too much protein, then it increases the gout?
I think you're talking about the influence of diet on uric acid and all that sort of stuff. There is an influence of it, but you may have seen there was a very interesting article in the Globe and Mail within the last couple of weeks, because there's this image of patients with gout as being fat, lazy, they drink too much, yada yada, all that sort of stuff. That's incorrect. There's a huge influence of ethnicity. Southeast Asian people eating a Western diet are, much more susceptible to it. Now, there's this other thing around alcohol, and people say it's beer, it's all forms of alcohol. But I say to my patients, you can either take a pill or you can give up booze. What do you want to do? And you can invariably the answer is I'll take the pill. So and I've kind of got a funny anecdote. I look after this guy who works for Alberta Premium Distillery. They make the rye, And anyway, he was in an awful state, but we were able to get him sorted out, and he sent me a card last Christmas. And he had this beautiful card anyway, but he sent along a 2-litre bottle of Alberta Premium. Now, I'm not a whiskey drinker, but I said, I'll have to try it, and it's absolutely awful tack. And then the next time I met him, I said, do you like that stuff? And his answer was, you get to like it.
Just a quick on top of that question, which is a really important question. So we're talking about 20 grams of protein at a meal. That's 60 grams per day, 60 to 70 grams a day. So that's not too much protein. And the people, of course, as a disclaimer, that should not have too much protein are those with have renal or kidney issues.
Okay, thank you. My last question. Sorry. My second question is that you all dealt a lot with the with the ankle talus and fibula tibia and or other portions. But what about the metatarsal itself? Like Martin, he had that motor neuroma nerve ending with the metatarsal. So what do you do with that? Like you guys have been saying your presentations with all these other ones, and I know time is of essence, but is there anything you can recommend any of you to deal with a lot of metatarsal pain in both in bilateral feet? Thank you.
Yeah, there's lots of different options it really depends on what the cause of the pain is. Forefoot pain is a very broad topic that we can't really tackle today. But there's lots of different treatment options, including custom shoe inserts, as was alluded to. Injections, surgeries are kind of the last resort, as they usually are. But really for that sort of thing, seeing a foot specialist and assessment of what the actual cause of the pain is, because there's lots of different reasons that you could have pain in that area of the body, for sure.
Back here, please.
All right, so this is kind of a question for the whole table. I played American football up to a semi-professional level here in Calgary, and I had repeated ankle sprains as well. And as I'm trying to be active to this day, I wear a brace similar to the ones that volleyball players wear, the hard plastic sort of style. Is there anything that you'd recommend outside of using that brace to continue working on ankle strength and to help reduce those injuries?
Well, actually, you should talk to the folks from the Sport Injury Prevention Research Center. So they've been pioneering some work in terms of balance control. So using a simple foam pad called an AirX pad. You can think about it as like just standing on a pillow. So improvements in balance, which was alluded to in terms of proprioception, but certainly getting your ankle muscles stronger. So the brace is literally a prophylactic. It's there in order to help the muscles do their job. So obtaining proper balance and working on a dedicated muscle strengthening program for the ankle muscles, you can eventually replace that brace. That would be the hope. I think that's why you're asking that question. But balance and strengthening are absolutely key. And it's something that you do on a daily basis. Right here.
So I just had,
We're just not finished yet.
Oh, sorry.
I was just going to add to that. That being said, there's a point at which there's two things at play in any of these sorts of injuries, ligaments and then muscles and tendons. Rehabilitation is going to strengthen your muscles and tendons, which help with your balance and your strength and everything. At one point, when your ligaments are damaged enough, they can't overcome that deficiency. And that's when you go see someone like a surgeon about fixing your ligament problem in the ankles. And that would be a very common thing that we're seeing people for is chronic ligament instability in the ankles.
So I'm just going to add one quick thing in here. Actually, it's not going to be quick, but it's related to the muscles. And so this is this little orange ball here. That I thought they were yellow. That's why I said yellow earlier. This is your cheapest massage therapist. No offense to massage therapists that you'll ever have when you go traveling. So this ball, yes, works on grip strength, but you can also use it for the muscles of your foot to strengthen those muscles in your foot. So getting your toes to move and using it as a bit of a friction on your foot. It's also unbelievably good for the piriformis. For those of you who don't know what that is, it's right in the center of your derriere that you're sitting on right now. And so you would put this underneath that and roll that around to keep that one. And then it's also very good for your back. So if you put this in the middle of your back on a wall and roll it, or on the ground and roll it, you can get a little bit of massage relief there. So please think about these balls, take them with you, and you can use them. And I'm typically talking about muscle in this case.
Well said.
so I had two quick questions regarding gout and inflammation, because I do get gout and I'm fairly young to get that. One is, I guess, on the big talk on ketogenic diets. I know they talk about a rich diet, etc., and I know I've done self-experimentation of cycling on ketogenics, and yeah, you get the gout symptoms right away, but it seems to actually drop off and reduce, I guess, inflammation in the joint. And I'm wondering if there's any studies related to that on, I guess, uric acid and reduction of uric acid. And then I guess the second one is a recent study on increasing your folic acid and vitamin B6 and B12 reduces, I think, hyperuricemia. And if you could speak to that possibly.
Sure. Yeah, happy to take that question. So, and as a young person, if you really do have gout, as a young person who has gout, you're likely an under excreter of uric acid. So, and I think I alluded to earlier on that the highest incidence of gout is in New Zealand Maori because their kidneys don't handle uric acid well. So you need to be medicated for that. About 10% of it would be in what you actually eat and drink, and it's always good to eat a good healthy diet. Protein, you need it for your muscle. The one supplement that's been shown to aid or to decrease the production of uric acid is vitamin C, because vitamin C works as an antioxidant. Vitamin B12, folate, all that sort of stuff is probably good for you, but there's also a myth around kind of cranberry juice and a few other things, but vitamin C is the one supplement. We have very effective medications to stop your body making uric acid. We don't have very effective medications to help you excrete it, but to actually stop you making it, we do. And once you go on those meds, you're usually on them for life.
Over here.
Thanks for coming out today. It's been very interesting and informative. I appreciate it. I have a question about tendon treatment and repair. I might be slightly off topic, I'm not sure, but do any of you have any research and advice on treating tendon treatment and repair outside of surgery?
Nope. Awkward silence.
Well, outside of surgery, we pretty much rely on your body to do the job. Your body has the amazing ability to heal all kinds of injuries, including tendons. Unless a tendon is completely ruptured, meaning the two ends aren't connected anymore, then for the most part, that can be treated without surgery. And different options, at that point, we're talking more about physical therapy and rehabilitation. possibility of some injections. But outside of that, there's not really anything that I'm aware of, at least, which on the horizon as far as new treatments for tendon injuries.
Over here. Oh, sorry.
I just had a question for Dr. Ferber. It's really interesting the work you're doing on looking at kind of creating a early warning system for preventable injuries. But I was just wondering about the graph you had. What were some of the factors that you were looking at in creating that profile, like stride length? Like what was creating that snapshot for those particular athletes?
Yeah, that's a great question. So it's a multi-dimensional problem. There's not a super simple answer for it, but I'll try to be. We collect information on stride rate, stride length, your cadence, how much you bounce up and down, sway side to side, your velocity of travel, the elevation that you're traveling on, like level ground, uphill, downhill, the temperature outside, your braking force, how much force you impart on the ground with each step, and we're collecting that data on a step-by-step basis. So the way machine learning works is you take all of that data and you input it, and then you tag it with certain information in terms of injury or not injury, for example, or male or female if you're trying to understand the differences there. So what I can tell you there is that graph mostly boils down to how much you bounce up and down and how much braking force is occurring. So it's a 14-dimensional problem, but that 2-dimensional graph is mostly braking force and how much you bounce up and down. Yeah.
Yes, my question is to Dr. Ferber and also to Patricia Doyle-Baker. So it seems like nowadays there's a lot of stuff going on with the brain and movement, and with motor and sensory cortex and cerebellum. Have you guys found a correlation with regards to falls and with regards to running injuries and things like that, and the correlation between the two?
Well, I'm the dumb biomechanist, and I don't deal with the neuromotor system at all, so I'm going to turn that over to Tish.
Well, I'm the equally dumb exercise physiologist, but I'm in good company, so I'm really pleased about that. So, on a very general answer, I mean, that's a very excellent question to ask, because anytime that you involve the muscle, you involve the whole firing system mechanism, and that then, of course, is developing neural pathway or strengthening the neural pathway. And the human body is so amazing that even as we age, some of those neural pathways can still be developed and regenerated. And so that the more exercise that we do, the more neural pathway we have, and the better, of course, our brain is able to facilitate that. Now, that's not exactly answering your question, but it did give me an opportunity to say that the more exercise you do, the better your mental health.
And then, and very quickly, so we did a study with active older adults, and we wanted to look at what's the variation in how you step. So one step is never the same as the next. And mind you, this is on a treadmill, so all external factors are limited as much as we can. And we know that when muscles are weak, one step is very unpredictable compared to the next step. There's a lot of variability, meaning the motor pattern itself is not consistent. But when you get muscles stronger, and this might even go back to the gentleman's question about tendons, we were looking at a group of individuals with a tendon injury in their ankle. Once the muscle gets much stronger, your predictability increases. So now the next step, your body knows what to expect. I don't know if that has anything to do with falls or not, but I know when muscles get stronger, you move in a more predictable fashion, and that reduces injury.
We have a supplemental here.
I'd like to add something to that. So I had a previous life as a physiotherapist before I did medicine, principally because I was a failed athlete. I had so many injuries. I never succeeded in sport. But what we showed when I was a physio, I did a lot of work around stroke and rehab. And patients who'd had a stroke, the best predictor of getting back to walking and not falling was rehabilitation of the normal movement of the trunk and pelvis first. So before you did anything else, you had to address that first with your mind. And it was phenomenal stuff, really.
Back here.
Yes, this is mainly a question for Dr. Patricia Doyle-Baker. For a person in their 60s, late 60s, can you regain your muscle versus your fat, those 3 slides that you had? Can you regain mostly muscle if you have, say, something like rheumatoid arthritis? Can you regain that in the upper body with the exercise?
All right, so, you know, miracles do happen, but it's how big you want them to be. So, you know, over the course of our lifetime, we lose muscle mass. And so, you know, about 1% a year after the age of 55 kind of thing. So the key to think about this is to maintain your lean mass and to make that the best quality lean mass there is. So I often say to people today, and particularly when we have patients or clients come in, that let's just talk about maintaining your weight and improving the quality of your muscle first. And so you can improve the quality of your muscle. Now, whether you gain more muscle mass in terms of actual, you know, bulk, that's a bit different. But the quality of the muscle can be influenced, and so your recruitment pattern can change. And if you change your recruitment pattern, you have better firing, and therefore you have better opportunity to prevent falling.
So if you improve the quality, can you regain some of that power?
Absolutely.
Okay.
Power is surprisingly easier to gain than strength in total strength is. So you can regain power definitely.
First of all, thank you for all your presentations. They were very interesting. My question is around supplements. I've been taking glucosamine for a number of years, thinking that will preserve the cartilage on my joints. And I'm just wondering, have I been just wasting my money on buying glucosamine, or is there any validity to that?
Hot topic.
The research surrounding supplements like that is quite variable. Some studies have shown that glucosamine can help symptoms of arthritis. So, you know, big randomized studies that show, oh, well, this actually helps people's pain compared to placebo. Unfortunately, a lot of literature surrounding supplements like that is funded by the people who make the supplements. So you have to kind of decide what to take from that. In general, when patients ask me about this, I usually tell them that I don't think there's no evidence to show that it's doing any harm. If they find a benefit in actual symptoms, then go ahead and use it. The only thing that hurts is your pocketbook, as you mentioned. I don't know of any well-done quality research by an independent party that shows that it prevents arthritis.
First of all, thank you very much for your information today. It was wonderful. And thank you for dispelling the myth of 10,000 steps. But my question really is about gout. When you normally think of gout, you think of this big toe stuck up in a pillow and it's painful and red and everything. But is it possible to have gout without the pain but just the swelling?
So yeah, that's an excellent question. So yeah, and you alluded to it being your big toe. Big toe, as I said, is about half the presentations, and about 90% of people will get it in the big toe at some stage. You can get gout in any joint. In postmenopausal women, the most common joints to get in are in the small joints of your hand, actually. Gout is always painful. So you won't have an acute attack of gout without a hot, tender, red, swollen joint. In other words, you can't ignore it. So you can have swelling without pain, but there's multiple different causes of that. But you know, it's not typically an acute attack of gout. However, if you remember on some of the slides there, you see those lumps that kind of develop around joints. They're called tophi, and they're collections of uric acid crystals that are hidden away by our immune system, but they can become active. So you can have those kind of build-ups that are swellings without actual pain, but if they become active and you get an acute attack, it'll always be very sore, hot, tender, red, swollen.
Okay, thanks very much.
I have osteoarthritis, and recently my knee swallow and very strong painful, and they limited my activity. After take X-ray last week, doctor recommended injection. I was wondering which kind of injection has a benefit for me and no side effect. Thank you.
The two most common types of injections for any type of arthritis, ankle, shoulder, hip, knee, are either a corticosteroid or steroid injection, or what's called a viscosupplement or a lubricant injection. Based on research, both have about the same effect, which is typically 3 to 6 months of pain relief. Now, a steroid is really just the most powerful anti-inflammatory delivered right to the site of inflammation. And the lubricant is just a synthesized molecule that normally occurs in our joints. As far as side effects, both can have some local side effects of swelling, irritation, pain. Sometimes the injections don't work. The steroid is covered by Alberta Health, and the viscosupplement is not. So there's not really necessarily one that's better than the other, and the most common one would definitely be a steroid injection, which is effective.
Hi, thank you for your presentations, everyone. This is maybe for Martin Nash, I'm not sure though. I have end-stage arthritis in my toe joint. I just got a cortisol shot. And my concern is I see a foot doctor, I also have a physiotherapist, but no one seems to be evaluating. What I can attest to is that it starts the whole body, the holistic treatment, and you had mentioned sort of a treatment plan or a whole body approach so that, you know, obviously if I'm not walking properly, you know, it's been impacted. I'm starting to feel it in the knees when I try to do some cardio, back and shoulder, etc. So who does that? Like, how do you get that sort of overall treatment plan? I find physiotherapists are very much one part of the body. Can anyone speak to that?
Yeah, it's frustrating. I get it. So honestly, I would go see somebody a sport physiotherapist, so designated as a sports specialist. So, yeah, we can talk. I'll give you some recommendations afterwards. Yeah, I understand. Like a lot of times practitioners are focused on your foot because you're complaining about your foot, and they're going to try to fix your foot. And it's much more comprehensive than that. Generally, a sports physical therapist has a little bit more holistic view. I'll come find you after.
What's Martin's view on that? I'd be interested in it.
Well, I mean, for me, we saw, as I said in preseason, we saw all these different doctors. Like you said, you didn't just go to one person. I went to, you know, we saw a surgeon, we saw a doctor, we saw a physiotherapist, we saw a posture specialist, and they all came together, and the physiotherapist diagnosed the plan for us. It was a sports physio in the end that designed the plan for me to rehabilitate my issues.
I think this is a big problem, and Tish and I were actually talking about this before the presentations today. About this is one of the troubles we're running into with the specialization in our professions. You know, in surgery, for instance, my elective practice is from the middle of the shin down, and that's it. And it kind of has to be that way just because of what we're doing. But we're starting to run into the problem of specialization. There's fewer and fewer people who are, you know, generalists. And so I don't have a solution for you, unfortunately. Maybe Reed does, but I definitely can empathize with the fact that I have a lot of patients who are coming to me with a similar problem, and I'm like, I'm the ankle guy, you know.
We have time for one more question, but before we get to it, I just want to give a little heads up. Someone's lost a pair of eyeglasses in the room somewhere, so if you can keep an eye open for some rogue glasses or don't step on them, that would help whoever the lost glass owner is. And we'll move over here now.
Thank you for taking my last question. It sounds like you guys could use a nurse navigator to pull all the faculties together. I actually have two quick questions. This is for Paul. What do you think about the idea of decreasing inflammation by diet for rheumatic arthritis?
Okay, so there's this kind of notion of an anti-inflammatory diet, and you know, there's for lots of different conditions. So I've see patients with all different forms of immune-mediated inflammatory arthritis. Gout being one, and obviously the most common. Eating a good, healthy diet is good for you, because it makes you lose weight, and you would use less junk food. The most pro-inflammatory substance is actually conjugated sugars. So it's like, it used to be fat was the problem, but now sugar is the problem. So you'll find with these anti-inflammatory diets, most of them cut out fructose and or sucrose and high fructose corn syrup, and they are good for you. Whether they'll actually improve your arthritis or not is a moot point. There's no real evidence for it.
What about the gluten?
Gluten, avoiding gluten if you're celiac is good. If you're not celiac, it makes no difference.
Okay, thank you. Dr. Ferber, last question. How can an active recreational senior person get involved in your study?
Oh, that's a great question. Just send me an email. So my contact, I'm easy to find. If you type in Reed and bow tie, my picture usually pops up. But we have a number of trials going on. I have a research manager who can take your information as well. And as the WeTrack, as the wearable program continues, we will be seeking this crowd in terms of participating in our studies. We want to tag you like wildlife and follow you out in the real world. That's really what WeTrack is all about. Yeah, so thank you for that. I like
Thank
that
you.
pitch.
Will I need a new password? Well, with that answer, ladies and gentlemen, we're going to bring to a close the 2018 Wood Forum. I would like to thank all of you for attending today. A special thanks to Dr. Donna Wood for coordinating all of this, and of course to the McCaig Institute for Bone and Joint Health, and thanks to Jeff and Marilyn for joining us today on behalf of the family. Terrific work. I think a very eclectic presentation today, time well spent, and lots of follow-up questions. I'd invite you to visit with the partners. I believe a few of our marquees are around for a while. I know Martin's got practice to get to, so he might be bolting out of here as quickly as he can. And again, thank you very much for joining us on a beautiful Saturday afternoon at the University of Calgary.